In this section, we'll start to, after we finish the techniques, either vital or non-vital, we'll talk about the pulpotomy specific, because as we said, this is the core of the pulp therapy in the primary teeth. What about the pulpotomy clinical procedure or technical procedure? First of all, removal of caries, complete removal of caries using rose round burr or round burr or invert cone, whatever the armamentarium or the burr it's convenient to you, use it with a complete caries removal. Be cautious, take your time in complete caries removal, not leave any remnant caries in your access, complete caries removal before starting the access to the pulp chamber to avoid, which is a very important cause, to avoid any introduction of any bacterial debris to inside the pulp, leading later on to flare up and failure of the case later on. First of all, complete removal of decay either by round burr or inverted cone. This is the only instrument you should select. Second is deroofing. After you make a complete deroofing, as we see here in the photo, after you make the complete deroofing, you will found in a drop, if the caries sent to the pulp, you found the drop, which is you are now inside the pulp chamber. Remove the round or the inverted cone burr and put your stone, tapered finished round stone, tapered finished stone or Fisher burr, whatever, to removing from the side wall to make what's called deroofing and removal of the axial side wall. It's very important, guys, to apply this deroofing, not deflooring. If you use the round burr, if you make a deroofing with the round burr with the inverted cone, you will remove the dentium from down. You make a perforation, moving in the furcation area. But you change the burr to make the moving over the axial wall from side, that we've seen here, deroofing. Move from side to side, drawing to your axis either in lower or upper. Extreme care during the first drop is very care with the support, can overcome this with the support to avoid touching the furcation area. What about the finishing after the make deroofing? The straightening of the wall. Your axis should be straight, either straight or a little bit diverged. Not recommended to make it converged, because if it's converged, maybe inflamed pulp tissue in the coronal part, may be remnant here, make a problem to the case. It's very important for us to know how I will draw, either in lower trapezoid or rectangular shape, my axis. In upper primary molars, it will be triangular shape, apex palatal and base buccally, and then in the anterior, it will be like permanent oval shape. So first of all, complete caries removal. Second, it will be the drop and change the burr to make the deroofing, and finishing the wall. The wall should be straight or slightly to be diverged. It's very important here, as we've seen, how to evaluate my work. First, to see all your, as if you're staying on the tongue of the child and looking to the axis, see all of us without unobstructed vision. As we've seen here, the wall is straight or slightly to be diverged. Number two, moving the explorer or the probe between the two orifices, as if you're moving smooth, regular as a glass. As if you're moving this sensation, you're moving in a glass. This sensation moving from the mesial to the distal, and then finally moving the probe from the orifices to the occlusal without any catch, without any catching or remnant pulp tissues found. So that in order to evaluate your work after making your access in the clinic, number one, see all your orifices, occlusally topographic view, all the wall straight or slightly to be diverged. Number two, moving the probe in between the orifices, as if you're moving in the glass. The number three, the dental probe from the orifices to up, as if without any obstruction. This is a very important, very important radiograph should be seen after you make the obturation, is a dome shape. What's the mean of the dome shape? That the furcation area is not touched by any mean. And then after you make your access cavity, control bleeding. Moist cotton, leave it 2 to 3 minutes, leave it in the access to control the theater of the operation, not to control the bleeding. The bleeding is controlled through the perfect professional access. Again, the bleeding is controlled not by the medication or by cotton, but by your actual professional access. It's all straight, no any remnant of pulp, inflamed pulp tissue, seeing all the orifices, making the correct technique in the correct case selection. Then using the medication, ferric sulfate or whatever glutaraldehyde or hypochlorite we will discuss later on, use it for 1 to 5 minutes until after removal. You see here, as you see here in the case, brown stump, the effect of the preservation of the ferric sulfate on the orifices, which indicating the pulp fixation and preservation. So, what is this is a very important point? What about the common cause of non-stop bleeding? You will ask. You will get the question now in your brain. Doctor, I make all my access now, but there is still bleeding. There is 4 causes of non-stop bleeding after you make the correct access. Number 1, inflamed pulp due to the wall's little bit conversion to that inflamed pulp. It's here and there making the bleeding. The wall should be straight, slightly to be diverged, seeing all the orifices, all the pulp chamber without unobstructed vision. If there is inflamed pulp, try by an excavator, try to cut this inflamed pulp tissue, straightening of the axial wall. Number 2, severe gingivitis, because the caries come in mutually between D and E. In proximal, food accumulation in between the gingiva, leading to severe chronic gingivitis, so that by default there is some bleeding may come to your orifice and your axis. So take care to separate this bleeding and separate this inflammation by cleaning this area and put a moist cotton with the pressure in this area for 2 to 3 minutes to control this inflammation of the gingiva. Either inflamed pulp from the orifices, so they go through, if you found it, this go through partial pulpectomy, or perforation, black, dark red bleeding, offensive bleeding from the furcation area. Check it by the color of the blood and the amount of bleeding, and by an radiograph. By default, we go for extraction for this case. Then applying the obturating material, zinc cyanogenol, by a moist cotton or by a condenser to deliver it in the space or using manual. Be sure that zinc cyanogenol limited inside the pulp chamber. And then this is how this technical pulpotomy will make, starting from the axis, then complete caries removal, then the drop, deroofing, then reshaping or drawing your axis, lower or upper, and then putting the moist cotton, then followed by the ferric sulfate, either formiclozole or ferric sulfate or glutaraldehyde, the medication, then by the obturating material. This is the straightforward approach for pulpotomy in the primary teeth. Thank you.